Patients undergoing general anesthesia and surgery undergo a lot of complex physiological changes, which complicates the diagnosis of allergy in intra-op period. In this section, I will talk about perioperative anaphylaxis. Now, perioperative anaphylaxis, it can be life-threatening if not recognized fast and managed accordingly. It can be catastrophic for the patient. Now, in this section, I will talk how to recognize it, how to manage it, and whether if it is happening intra-op, we should proceed with surgery or abandon the surgery. All these things we will discuss in this topic. So let us start our discussion with the incidence of perioperative anaphylaxis. What is the reported incidence? Now, the previously reported incidence is 1:350 to 1:20,000 cases. With more recent report narrowing to, with more recent report narrowing the range with a better definition of perioperative analysis to 1 case for every 1,000 to 10,000 episodes of anesthesia, right? 1 case every 1,000 to 10,000 episodes of anesthesia, right? So this is the latest reported incidence, 1 case for every 1,000 to 10,000 cases of anesthesia. Now, it is rare, it rarely occurs in children, it is more common in adult, and in adult it is more common in female. So, less frequent in children and more commonly seen in female compared to male. The IgE mediated, more commonly seen in female. Now, definition. How do we define? Definition of perioperative anaphylaxis itself is very important to remember. So, how do we define it? Anaphylaxis. Anaphylaxis is potentially lethal reaction, usually resulting from the sudden clinically significant release of mast cell and or basophil derived mediators in the circulation. So it is potentially lethal reaction which is happening due to sudden and clinically significant release of mast cell and or basophil derived mediators in circulation. Now, these mediators causes catastrophic reaction is what we will discuss about. Now, the mechanism is varied. Previously, it was divided into anaphylaxis and anaphylactoid reaction. Nowadays, such kind of differentiation has been removed. The reason, the presentation of both anaphylaxis or anaphylactoid reaction is same, and number of potentially, let's say, the culprits causes the allergic reaction by multiple mechanism, right? So, the previous nomenclature of anaphylaxis anaphylactoid reaction is nowadays becoming obsolete. Now, remember that mechanism is either IgE generated release of the mediators, which constitute 60% of the all cases, or non-IgE, that is formally called anaphylactoid reaction. This was what was called anaphylactoid reaction, and this is mediated by Ig, G or M. And third is non-immunogenic mechanism, direct mast cell mast cell release of histamine. So non-immunogenic mechanism, right? That is direct release of histamine from the mast cell. So these are the three important mechanisms. So if I let's say exactly define the mechanisms, IgE mediated activation of mast cell and basophils. The most common example for this mechanism, causing allergy by this mechanism, is your antibiotics, your penicillin, and few neuromuscular blockers. Now, what is unique about them? That can be evaluated with skin test in vitro for allergen-specific IgE, require prior exposure of allergen to allergen or cross-reactive allergen, amenable to desensitization in some situation. Then we have immunogenic mechanism not involving IgE. The second one, that is anaphylactoid reaction, mediated by IgG or IgM. Example, reaction to dextrin and protamine. Here, this is formally called anaphylactoid reaction. Skin testing and in vivo IgE testing not useful. Pre-treatment with glucocorticosteroid and antihistaminic may be useful. Then we have direct activation of mast cell and basophil, causing the release of the mediators from this. Reactions to radiocontrast agents, opioids, and neuromuscular blocker by this mechanism. And formerly it was also called anaphylactoid reaction. Skin testing or in vivo vitro IgE testing is not useful. Pre-treatment with glucocorticosteroids and antihistamine may be helpful. Slow administration of the responsible agent generally minimize the reaction. So this is three important mechanisms, and one drug can cause the allergic reaction by multiple mechanisms. But the important thing is that by all these three mechanisms, the clinical presentation is same. Clinical presentation is same and the management is also same, right? Okay, so what are the culprits? Intra main culprits which causes perioperative anaphylaxis. Now, the most common is your antibiotic, your neuromuscular blocking agents, neuromuscular blocking agents, your neuromuscular blockers, neuromuscular blocking agents, then chlorhexidine, and dyes, the blue dyes. These are the most common culprit. Okay. Now, if you see them, antibiotic. Now, antibiotic administered pre, intra, or post-op, immediately after during surgery, right? They are the leading cause of IgE mediated anaphylaxis reaction. So, antibiotic administered before, during, or immediately after anesthesia. Immediately after anesthesia is leading cause of IgE mediated perioperative anaphylaxis. Is leading cause of IgE mediated perioperative anaphylaxis. And the most incriminated antibiotics is your beta-lactam antibiotic, your vancomycin, your quinolone group. Vancomycin, quinolones. Now, the second important culprit is your neuromuscular blocking agents. Neuromuscular blocking agents. Now, their mechanism is by multiple way, IgE or non-immunogenic. And they are the second most important cause. Some countries report it as the most important culprit for causing the perioperative anaphylaxis. Like in the database reported by in France, the neuromuscular blocking agents are the most important culprit. But US, UK, their database says it's antibiotics, which is the most common culprit. And in neuromuscular blocking agents, rocuronium, succinylcholine, your atracurium, pancuronium, D-tuberculare. Atracurium, pancuronium, your D-tuberculare. These are the common culprits. Okay. Then we have chlorhexidine, that is the topical antiseptic solution, which is another culprit. So chlorhexidine, which is a topical antiseptic, which should also be used carefully. Central venous catheter insertion, when the chlorhexidine, there are a lot of case reports, the chlorhexidine, that is topical antiseptic chlorhexidine, when it was used during CVP catheter insertion, the allergic reaction was noted in the patients. Then blue dyes, which is used for delineating the lymph nodes in number of cancer surgery, is another common cause of perioperative anaphylaxis. Now, less common cause is your colloids like your starch and dextrin, your hypnotic IV anesthetic agent, hypnotic induction agent, your barbiturates, and the non-barbiturates, especially your propofol and etomidate. Now, propofol, the allergic reaction which is being caused by it is not because of the egg, because it contains the egg extract. It is not because of egg it is causing this anaphylactic reaction, some other reason. So hypnotic induction agent is one of the other cause. Then opioids, especially your morphine, latex. Nowadays we see latex free products, so less is implicated. And Sugama-dex, a new reversal agent, Sugama-dex. So these are the less common causes. Okay. Now, so if you see this list, that what is the mechanism of these drugs causing perioperative anaphylaxis? Neuromuscular blocking agents, IgE mediated and non-immunogenic pathway. Your antibiotics, mostly the IgE mediated, okay, but some by non-immunogenic pathway as well. Then your chlorhexidine, mostly by IgE mediated or by non-IgE mediated immunogenic reaction. Blue dyes, IgE mediated. Hypnotic induction agent. The barbiturates can cause allergic reaction by any mechanism. Non-barbiturates, opioids. The non-barbiturates also by any mechanism, the propofol and etomidate. Opioids, mostly by IgE mediated and non-immunogenic. Colloids, plasma expander, dextrin by any mechanism. Sugama-dex, IgE mediated mostly. Latex, IgE mediated. So you can see most of them can cause perioperative anaphylaxis by multiple let's say mechanisms, right? So one mechanism cannot be delineated, but most common intraoperative anaphylaxis, the mechanism is IgE mediated. Okay. Now, what is the clinical manifestation? This is very important. Whatever mechanism is causing the allergic reaction, the clinical manifestation of anaphylaxis or anaphylactoid reaction is same. And what is that? Hypotension or shock. 50% of perioperative anaphylaxis present with hypotension or refractory shock, that is cardiovascular collapse. Then patient can present with tachycardia, arrhythmias, dyspnea, wheezing, high peak pressure, bronchospasm when we are ventilating on ventilator, hypoxemia or decreased O2 saturation noted on pulse oximetry, decreased breath sound on auscultation, angioedema, face, lips and laryngeal stridor, etc. Hives, itching and flushing. Now, during anesthesia, basically the anaphylaxis, 3 important systems is affected: the cardiovascular, the respiratory and the skin. Now, the skin changes are less seen, the reason being that the patient is covered in drape and all, so we normally miss it. So it's cardiovascular and respiratory which is more we let's say, which should more raise our suspicion for anaphylaxis. Number of times we miss to see the skin changes which is happening in anaphylaxis. Cardiovascular collapse is one of the most common initial presentation of perioperative anaphylaxis. So let us compare that if the anaphylaxis is happening in patient under GA, how it will present, and patient not under GA, the general patient, how it will present. Let me compare it for you. So I told you 3 important systems is affected: respiratory, cardiovascular and skin. So what are the difference we will see? Upper respiratory tract and laryngeal edema. If it is a normal patient, they will complain of throat tightness, change in the voice quality. But if patient is under anesthesia, there would be difficulty in intubation when we will do the laryngoscopy. The upper respiratory changes caused by the allergy make the intubation difficult. Now, lower respiratory tract or bronchospasm. In normal patients, not under anesthesia, shortness of breath, wheezing and cough will be there. But when a patient is under anesthesia, there would be increase in the ventilatory pressure needed to inflate the lung, increase in end-tidal CO2 because of improper ventilation, decrease in arterial oxygen saturation. So EtCO2 will increase, saturation will decrease, and ventilatory pressure will increase. It will be difficult to ventilate because of the bronchospasm. Then cardiovascular system, hypotension. Normally, other patient, dizziness, tunnel vision, collapse without signs. But under anesthesia, cardiovascular collapse is common, most common. First detected manifestation in 1/2 of the cases. This I want to stress repeatedly, that cardiovascular collapse is most common, first detected manifestation in 50% of cases during perioperative anaphylaxis. Now skin changes, which we normally miss because patient is under drip. Now in patient not under anesthesia, flushing, itching, urticaria. Patient under anesthesia, it will present as cutaneous sign and symptoms, right, which may be present or absent but may be hidden by the surgical drapes. And patient themselves cannot complain of itching and all, which another patient not under anesthesia would complain. So under anesthesia, the manifestation which we need to focus on is the cardiovascular collapse, right, and bronchospasm due to bronchospasm which causing difficulty in ventilation of the patient, right. So these 2 things which we have to focus on, okay, while they are diagnosing perioperative anaphylaxis. Now just very quickly, how do we diagnose? What is the criteria for diagnosing the anaphylaxis? Now there are various ways of diagnosing anaphylaxis. First method is acute onset of illness, minutes to several hours, with involvement of skin, mucous tissue or both. That is, patient will have generalized hives, pruritus, flushing, swollen lips, tongue, etc. And at least one of the following, that is respiratory compromise or cardiovascular compromise. This is typical anaphylaxis. All the 3 systems is involved: skin, cardiovascular, respiratory and cardiovascular. Then 2 or more of the following that occurs rapidly after exposure of likely allergen, minutes to several hours: involvement of skin, respiratory compromise, reduced BP or associated symptoms, persistent gastrointestinal symptoms. Any two or more, okay. Then reduced BP after exposure of known allergen for the patient, minutes to several hours after exposure. In infant or children, low systolic BP or greater than 30% decrease in the systolic BP. Adults, systolic BP less than 90, greater than 30% decrease in the patient's baseline. So if you see the third one, just the decreased blood pressure, just the cardiovascular response after the known allergen is enough to diagnose anaphylaxis. Well, number of patients, when they come to us, when we take the allergy history, they may not be able to tell us about the allergy history if they are not exposed to that allergen, right? But they can present with this anaphylaxis reaction on exposure of these allergens. So we should have a high index of suspicion. Whenever we see the cardiovascular collapse, unsuspected cardiovascular collapse which cannot be explained by any other thing which is happening in the OT, huge blood loss or something like that, the perioperative anaphylaxis should be in our mind, immediately in our mind. This is one condition which, if managed properly, can be completely reversed, within seconds. So you need to diagnose it. You should have a high index of suspicion. Okay, so how do we manage? So once I have diagnosed it, how do we manage? So first thing, it's an emergency. Remember, it's an emergency. So first thing, call for help. Call more people, senior people if you are alone in OT. Inform the surgeon and stop the procedure for a few moments. Ask for crash cart, right? Crash cart to manage the critically ill patient. Then check for the possible causes which you are giving to the patient, some drug, something like antibiotics, muscle relaxant, IV contrast, or blood products, or anything. If any ongoing allergen which you are giving can be a possibility, stop it immediately. Administer 100% oxygen. If airway is not established, if patient is under GA, if airway is not established, establish the airway, because later on with let's say edema of the respiratory tract or angioneurotic edema, it will be difficult to secure it. For hypotension, if patient is in hypotension, give epinephrine, guys, drug of choice. This is drug of choice, epinephrine. May repeat and escalate the dose 1 to 2 minutes and titrate to effect. What is the dose in anaphylaxis? Intraop, IV, if I am giving IV, then 10 to 100 microgram per IV dose. 10 to 100 microgram per IV dose. See, you take 1 ml of 1 in 1000 your epinephrine, that contains 1 milligram. You dilute it to 10 ml. So now in 1 ml you have 0.1 milligram. That is 0.1 milligram you have in 1 ml. That is 100 microgram. So that diluted epinephrine which you have prepared, you can go on giving 1 ml, right? 1 ml to the patient in incremental dose. Okay. If no detectable blood pressure, if patient goes into arrest, start CPR. You have to start CPR. And start CPR, start epinephrine infusion, start fluid, because you know here what is the cause. The cause is anaphylaxis, which has led to the cardiac arrest in the patient. For ongoing hypertension, start the IV infusion of epinephrine, 2 to 10 microgram per minute, 2 to 10 microgram per minute dose. Okay. So the drug of choice for anaphylaxis, intraop anaphylaxis, is epinephrine. Intraop anaphylaxis can be life-threatening. Give IV epinephrine. Otherwise, out of, let's say, not under anesthesia, not during surgery, if someone goes into anaphylaxis, we normally give IM or subcutaneous 1 in 1000 epinephrine, right? 0.1 milligram per kg body weight. But under anesthesia, IV would be better for a fast result. Okay, IV would be better. So we would give 10 to 100 microgram, but rather start with 100 microgram only for the fast result. Right. Now, for bronchospasm, give albuterol 4 to 8 puff. Alternatively, 2.5 milligram albuterol in 2.1 ml saline to nebulize it via endotracheal tube. So albuterol, the short-acting beta blocker, for nebulization. And give methylprednisolone 125 milligram IV or hydrocot 100 milligram IV. And H1, H2 antihistaminic. H1 antihistaminic, diphenhydramine 50 milligram IV and famotidine or ranitidine 20 milligram IV. Okay, so H1, H2 blocker. So this is the management. Epinephrine is first drug of choice. If there is a respiratory compromise, bronchospasm and all, we nebulize with beta agonist. We nebulize with beta agonist, that is your albuterol, right? And we give steroid, that is 125 milligram IV, methylprednisolone or 100 milligram hydrocot. And we give H1, H2 blocker, diphenhydramine 50 milligram IV or your famotidine 20 milligram IV. And apart from this, we do the symptomatic management. We give 100% oxygen, we we do ACLS in case of cardiac arrest. So all those management according to the symptom of the patient, right? If patient is going into bronchospasm, we need to secure the airway as soon as possible. So this is how we manage the perioperative anaphylaxis. Just remember one thing, adrenaline has no contraindication. Any patient can be given adrenaline. So there is no contraindication of giving adrenaline to anyone. Remember always, the drug of choice for perioperative anaphylaxis is adrenaline. Okay. Now, if patient is still having hypotension, we can start more inotropes. Vasopressin for refractory hypotension, 1 to 2 unit bolus or infusion. Norepinephrine for refractory hypotension as an alternative, 2 to 10 microgram per minute. Continued fluid administration for refractory hypotension, 50 ml per kg after first 2 liter of fluid resuscitation. Consider vasopressin or glucagon, 1 to 5 milligram slow IV bolus over 5 minutes for refractory shock. If patient has received high dose of beta blocker, if patient has received beta blocker, right, go for glucagon to treat the refractory hypotension. Because beta block patient will not listen to any other drug. So you have to go for glucagon. And echocardiography to diagnose other causes of refractory hypotension. So if patient's blood pressure is not increasing, we can go with these management. We can go for vasopressin, norepinephrine, fluid as much as possible. We have to give a lot of fluid because it's a vasodilatory state. Then consider glucagon in case of patient who had received beta blocker, and transesophageal echocardiography if the expertise is available. So this is how we manage the refractory hypotension. But normally patient very well respond to epinephrine. So epinephrine is one drug that we have to look for. Okay. Once the patient is settled, or maybe even during when you are settling the patient, obtain 1 ml of blood in the red top tube for serum tryptase assay to diagnose it was really anaphylaxis. Ideally within 1 hour, but it may remain elevated up to 3 hours from the onset of event. Repeat tryptase after 24 hours to establish the baseline concentration. More than 11.4 microgram per deciliter of tryptase is diagnostic of your anaphylaxis, right? So we can get a tryptase assay done and confirm the diagnosis of anaphylaxis, which should be done within 1 hour, alright, within 1 hour, maximum 3 hours, within 3 hours. Now, patient has gone into perioperative anaphylaxis. Do we continue with surgery or we abandon the surgery? Well, the decision depends upon few very important things. It depends upon what was the severity of the anaphylaxis. Then it depends upon whether the patient has gone into whether the patient is at present in cardiopulmonary stability or not, whether the cardiopulmonary status is stable or not, and what is the let's say urgency of the surgery. So it depends upon the severity of reaction, the allergic reaction, cardiopulmonary stability, urgency of the procedure, right? So these 3 factors would guide us whether we should continue with surgery or not. Now, severity of the reaction. If the patient had grade 1 or grade 2, grade 1 or 2 anaphylaxis. Now, these are mostly with only cutaneous reactions. Now, we can proceed with surgery with no extra, let's say, risk associated. If it is grade 3 anaphylaxis. Now, grade 3 anaphylaxis, they have the bronchial and the cardiovascular manifestation. Now, studies have shown they are associated with more adverse effect, but continuing with surgery has no connection with those adverse effects. So, rather, we can continue with surgery. So, adverse effect or adverse risk is higher, but not related to continuation or discontinuation of surgery, but unrelated to continuation of surgery. So in this also we can easily proceed with surgery. We can, if the patient is stabilized, proceed with surgery. Why to? If the patient is stable of these manifestations, we can proceed with surgery. If it is grade 4 anaphylaxis, that is patient had landed up in cardiac arrest, grade 4 anaphylaxis, right? Patient was in cardiac arrest, you have resuscitated the patient after cardiac arrest, or patient is in refractory hypotension, then this is one condition in which surgery is frequently abandoned. Surgery is frequently abandoned, right? But this also does not have any evidence-based recommendation to abandon the surgery. That surgery has anything related with this, with the adverse event. Already this patient has a high mortality and morbidity. So continuation or non-continuation with surgery has nothing to do with it. But most of the cases in grade 4 anaphylaxis, at most of the centers, surgery is abandoned. But till grade 3, once the patient is stabilized, we can continue with surgery, right? Now, if a perioperative anaphylaxis happens, it is our responsibility to mention it in the record book of the patient, in the file of the patient, inform the patient personally about it, and attach the patient to a skin allergen testing clinic to diagnose that what is the most possible allergen which has resulted in anaphylaxis, right? So observe, and let's say once the surgery is completed in these patients, we observe the patient in intensive care unit for 12 to 24 hours, continue the glucocorticosteroid for next 24 hours and refer to allergist, and mention the event in the patient's record, inform the patient about the event, okay? So this we have to do for the further care of the patient. So this is how we manage perioperative anaphylaxis. Drug of choice, remember, is adrenaline. So you always have to think about adrenaline in these cases, okay? So I hope you will now manage perioperative anaphylaxis with more confidence. Thank you.